Hi, my name is Ben Click, and I'm a staff gastroenterologist from the Cleveland Clinic, and I'll be discussing surgical and medical prophylaxis of post-op Crohn's disease. These are my disclosures. Here are the learning objectives. And first, to review the natural history of post-op Crohn's disease. We know that surgery is not curative for Crohn's disease. In fact, most individuals following resection will experience a Crohn's disease recurrence. The data suggests that the majority of individuals, even within 1 year after surgery, will display endoscopic evidence of disease activity. This is followed by subsequent development of recurrent clinical symptoms of Crohn's disease and repeat surgery in up to half of individuals within 5 years. And what this natural history really illustrates is that recurrence, especially early, is often clinically silent, and we must rely on objective assessments to catch and monitor Crohn's disease early after surgical resection. And endoscopic disease activity is perhaps the best well described and has formed the backbone of our monitoring strategies. The eponymously named Rutgers score is perhaps the most well established of these postoperative scoring systems. And it really stems from the description of the endoscopic appearance of the anastomosis in the neoterminal ileum, with grades from 0 to 4, 0 being no activity, 1 being minimal activity, and then progressively more severe disease activity. And those lower scores have been collectively defined as endoscopic remission by subsequent trials using this scoring system, and higher scores have been termed endoscopic recurrence, as scores of 2 or more have been associated with the risk of subsequent clinical recurrence. And so the Rutgers score is perhaps our most well-studied and most well-utilized scoring system for this purpose. So it goes to say that if Crohn's disease recurs in the majority of individuals undergoing resection and is identifiable by endoscopic assessments, we may have 2 medical approaches to treating postoperative Crohn's disease. Number one, if we can identify and use medical therapies early to try and prevent or delay surgical recurrence after surgery. Or number two, we can watch with endoscopic assessments, and then treat individuals with evidence of disease activity. Well, which medications or which interventions work early to prevent or delay recurrence? Well, antibiotics have long-standing and wealth of data in this situation. Ornidazole in a prospective randomized trial has been shown compared to placebo to reduce recurrence rates at 1 year, with endoscopic recurrence being the outcome. But the limitation of ornidazole at this dose that was studied is that a lot of people could not tolerate it, and many patients discontinued the therapy. And when individuals discontinue antibiotic therapy for postoperative Crohn's disease, the Crohn's tends to recur shortly thereafter. There is some retrospective data that lower doses of a related antibiotic and metronidazole can be similarly effective, but again, this is retrospective data, but this patient population did tolerate the lower dose metronidazole more throughout the study period. Anti-TNFs or immune modifying therapies are perhaps the most effective for preventing or delaying postoperative recurrence. This is pilot data from Miguel Reguero and Pittsburgh colleagues early, showing that infliximab compared to placebo can dramatically reduce the rate of endoscopic recurrence. And this was subsequently followed by the pivotal global multi-center randomized placebo-controlled study of infliximab versus placebo called the PREVENT trial. And one of the outcomes for the PREVENT trial was endoscopic recurrence before or at week 76 in the 2 arms. And you can see here that infliximab significantly reduced the rate of endoscopic recurrence in this patient population. Notably, the primary outcome, as FDA mandated for the PREVENT trial, was clinical recurrence. And this trial just did not meet that primary endpoint. And so it is considered a negative study for its primary endpoint, but clear reduction in endoscopic recurrence, which is arguably the more important and meaningful outcome at this time period. It's not limited to just infliximab. All anti-TNFs seem to display the similar efficacy for this postoperative prevention as shown in this table here. And so it seems to be a class effect. So that's option number one. We can use medicines to try and prevent or delay postoperative recurrence. Either antibiotics or anti-TNFs are the most well described. Option number 2, wait, watch, and treat if we identify recurrence endoscopically. This approach was largely informed by the pivotal POKER trial, which looked at this question. And just to familiarize the group with the POKER trial, if you aren't familiar, the primary outcome of the POKER trial was endoscopic recurrence at 18 months. There were 2 arms in the POKER trial. The first arm was considered the active arm. And basically, the active arm was if we look earlier than 18 months, if we look at 6 months post-op, and we adjust the therapy that they're on based on the findings of that endoscopic assessment, meaning if there's disease recurrence, step up the therapy and treat those individuals. Can we reduce the subsequent endoscopic recurrence at 18 months compared to a standard treatment arm, which basically just had the colonoscopy at the 18-month time period? Patients were risk stratified before surgery, and those low risk for postoperative recurrence didn't receive any medication aside from the antibiotics for 3 months that all patients received. Those in the active or high risk arm, were received either thiopurines or adalimumab if they were intolerant to thiopurine or had previously failed thiopurine. So just by looking early at 6 months and adjusting therapy for those individuals with disease recurrence at that point in time, there was a significant reduction in the 18-month endoscopic recurrence rate in the active arm compared to the standard treatment arm. So this has really informed our postoperative monitoring strategies by looking early at that 6-month time period and adjusting therapies as needed. But how do we decide between these treatment strategies? Who gets meds and who should we watch and wait? Well, the AGA has published some nice illustrative risk groups of lower risk and higher risk for disease recurrence based on the available data. Lower risk individuals are generally older, non-smokers. This may be their first surgery for Crohn's disease, potentially a short segment of disease, and has had a long, slow disease progression to this point in time. Those individuals are lower risk and potentially considering endoscopically guided monitoring, not necessarily starting these individuals on therapy, but looking at that 6-month time period and starting therapy if disease activity is identified. High risk patients, younger, smokers, multiple prior resections, penetrating behavior with or without perianal disease, high risk for recurrence. These are individuals who need early pharmacologic prophylaxis, but still look at that 6-month time period at colonoscopy. And if there's disease recurrence at that point in time, either optimize or change therapy to address that. But what about the title of this talk, surgical and medical prophylaxis of Crohn's disease? Well, perhaps the most surgical attention in recent data has focused on the role of the mesentery in influencing postoperative Crohn's disease recurrence, and this has even been picked up by the popular press. We've long known that the mesentery is important in Crohn's disease or altered in Crohn's disease, but the exact interactions between the mesentery and the intestine in terms of influencing intestinal pathology is still being elucidated. We know that there's a lot of products that the mesentery produces that may influence the development of fibrostenotic Crohn's disease. And there's some emerging data that this may be more important than historically thought. So if the mesentery potentiates Crohn's disease and may drive fibrostenotic disease, there are potentially 2 surgical approaches to preventing post-op recurrence of Crohn's disease. Option 1, cut out more of the mesentery. This can be done through an extended mesenteric excision. Option number 2, protect or shield the anastomosis from the mesentery and that interaction, that environment that may influence the recurrence rate. So first, option number 1, the extended mesenteric excision to prevent postoperative recurrence has really been highlighted by Calvin Coffey and the group in Ireland. They published this study comparing a prospective cohort of individuals in whom they performed wide mesenteric excision to a historical cohort who underwent conventional mesenteric excision. And you can see that in the outcome of surgical recurrence, so repeat surgery for Crohn's disease, the wide mesenteric excision was associated with a lower recurrence rate, and this held true in their multivariable modeling. What about option number 2 for surgical prevention of Crohn's disease recurrence, the Kono S anastomosis? And we don't have time to go through all of the technical considerations for this more novel anastomotic configuration, but essentially it goes to create a spatulated hand-sewn end-to-end anastomosis, but approximating using a stapled approximated margin to support and protect that hand-sewn end-to-end anastomosis from the mesentery and create kind of an isolated environment away from the mesentery. And the Cone-OS anastomosis has been studied in a prospective fashion in the Supreme CD study and shown to be associated with reduced endoscopic post-op recurrence rates, both early and later, as well as reduced later clinical recurrence and no difference in surgical recurrence or surgical complications in the perioperative period. So potentially a role for a novel anastomotic configuration to influence post-op recurrence as well. Recently, the group from Cleveland Clinic, headed by Stefan Holabar, have described a unique or novel combination of these two approaches, combining extended mesenteric excision with a Cone-OS anastomosis, and it does appear to be safe in the perioperative period, and the influence on postoperative recurrence is still being studied at this point in time, but look forward to that. So in conclusion, for the surgical and medical Crohn's disease prophylaxis, postoperative recurrence is common, often silent, progressive, and we can identify risk categories by certain features. Early medical prophylaxis with anti-TNFs and antibiotics reduces endoscopic recurrence. I didn't present this data, but perioperative biologics have not been associated in a prospective trial, the Puccini trial, with post-op complications. So please don't let that influence our decision-making in this high-risk population. Endoscopic surveillance can guide post-operative management, and generally we start at that 6-month time period. Surgical techniques such as wide mesenteric excision, a Cone-OS anastomotic configuration may reduce recurrence risk, but really working closely with gastroenterological and colorectal surgical colleagues to identify the best approaches for this high-risk patient population can help optimize our patient outcomes. So with that, I thank you for your attention, and I hope you enjoy the rest of the meeting.